Well, hello, everybody. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you to today's live expert panel webinar hosted by Proficient Health. And it is called The Cost of Poorly Managed Referrals, which I know is an issue that a lot of you have dealt with personally. So I think this is going to ring true for a lot of you. There's going to be some good nuggets of wisdom here that are shared today. So looking forward to hearing from our speakers, which I will introduce in a moment. A couple of items of note before we get started. Everyone's joined today in listen-only mode. This is a traditional webinar format. You may not be familiar with GoToWebinar, but it's not like Zoom, so we can't see you or hear you, so don't worry about that. But we do want to hear from you. And so we're going to have some time for some Q&A towards the end, at which time we're going to answer some audience questions. If you have a question that you'd like to either direct to one of our speakers individually or just in general, go ahead and submit that using your control module. There's actually a place for questions on there. Go ahead and put them there, and we're going to get to as many as we can during the allotted time. If for some reason we don't get to yours, don't worry, someone will reach out afterwards via email to answer your questions. And you don't have to wait until the Q&A. At any time during the presentation, go ahead and ask your question. Finally, the session is being recorded. So what's going to happen is when we're done here, you're going to receive an email maybe within the hour probably after we're done, and it's going to have a link to the recording, also to where you can download the slides. And so with that, you can review it, you can share it with colleagues. We hope that you do. And without further ado, let me go ahead and quickly introduce our speakers today. First of all, we have Mr. Mike Barrett, and he is the Vice President of Strategy and Business Development with Collaborative Health Systems. I've known Mike for a long time, and he's a great guy. He is let's see, the Vice President, I already said this, of Business Development. In his role, Mike works with provider organizations of every type to guide projects from concepts to implementation, configuring relationships so that all stakeholders achieve success. These partnerships include Medicare ACOs and other business operating partnerships, producing industry-leading value for all CHS constituents. Mike brings more than 35 years of varied healthcare experience to the CHS mission. He has held leadership positions in hospital organizations and large physician groups, as well as with IPAs and HMOs. Mike co-founded the National Association of ACOs with NACOS, which I know a lot of you have attended and do attend regularly, and served as chairman from 2012 to 2015 and board member through 2017. And he remains a member of the policy committee today. So good to have you, Mike. We also have Ms. Debbie Hooter, who is the executive director of WakeMed Key Community Care. And Debbie has extensive experience in ACO collaborations, data-driven outcomes, and managed care contracting. She is currently, as I said, executive director of WakeMed Key Community Care in Raleigh, North Carolina, which is a CIN, and it's owned by both WakeMed and Key Physician Group. Her experience includes working on both the payer and the provider sides of healthcare. She has worked for national payers such as Cigna and Anthem. And she has also worked for large healthcare systems such as Piedmont Healthcare in Atlanta, Georgia, and Prisma in Greenville, South Carolina. She has a passion for helping physicians coordinate and take better care of their patients using data-driven expertise, education, and communication. When Debbie is not working, she enjoys spending time with her two Shelties and traveling. And then finally, we have Mr. John Wagner, who is the VP of VBC Growth with Lucerna Health. I've also known John for a long time. He's a good buddy of mine. And John is a visionary in healthcare executive, specializing in strategies of value-based care, product innovation, provider integration, payment, revenue enhancement, value optimization, and execution. He has a broad range of experiences gathered from time spent with Florida Blue and Berkeley Research Group, which is a value-based care management care consulting group, and also ACO Health Partner, which is a physician's ACO. So he's really had experience on both sides So brings a wealth of knowledge there. He's been with Walgreens, retail health partnerships, and most recently, leading revenue optimization for Flagler Health, hospital system before joining Lucerna. He leverages his deep industry knowledge and relationships to drive Lucerna's growth. And when he is not working, he is enjoying long walks on the beach and all the other great things in Jacksonville Beach. I'm jealous. So welcome all of you. I think John's going to be kind of moderating for us today. So I'm going to turn it over to you at this time. John, welcome.
Thank you so much, Garrett. Appreciate you taking the time and everybody facilitating the opportunity for us to spend a little time with you. We're going to just take one quick second, and I'm going to ask Mike and Debbie. We'll start with Mike to just tell us a little bit about their organizations, just very briefly.
Collaborative Health Systems currently operates a little over a dozen ACO entities in roughly 20 states, and we have every flavor of that you can imagine. MSSP, several versions of MSSP, plus a couple of REACH programs. We also manage jointly 2 other REACH programs, Complete Health and what's called VB Cares. We call it VB Cares in Phoenix, Arizona, an FQHC-oriented entity. We also have Medicare Advantage health plans in a couple of markets where we take a % of premium contracts from Medicare Advantage health plans outside of our Centene siblings. So we're pretty broadly covered in the Medicare space. Our claim to fame for the moment.
Thank you. And Debbie.
Yeah, hi, my name is Debbie Cuter. I'm the Executive Director for WKCC in Raleigh, North Carolina. We are a jointly owned ACO between WakeMed Health Systems and a very large, fiercely independent primary care group called Key Physicians. We've been in existence for about 10 years, and we have about a little over 200,000 lives that are covered in our ACO. All products, with the exception of MSSP, but we're in commercial Medicare Advantage products, and I think that's it.
And I'll share a bit about Lucerna Health. We're an early stage company that really focuses on how to activate value-based arrangements between payers and providers, and not just contractual types, but really deep integrated relationships where we look to optimize the performance through deep rich data, patient activation, and a series of other kind of value-based enablement capabilities that if you were on the provider side, you may not actually kind of realize that these are the types of things you need to be successful. So considering the unique role we play, we're able to help pretty large provider systems be much more effective in these arrangements. So, and I think what's really important as we start to have this discussion about how referrals help improve the performance of our system. Let's take a second and just kind of talk about where we are as kind of healthcare delivery today, right? So just recently, Kaufman Hall published that the average health system in this country has a operating margin of about 1.1%. So if you're a $500 million hospital system with physicians and ambulatory assets, you're making a $5 million margin. So you're one accident away from being in the red, and so the system really is tight today. And Kaufman also published that employed primary care by health systems costs the healthcare system nationally about $1.4 billion today. So there's opportunities around effective, efficient management of employed docs within health systems. And I think a lot of that's because we have parts of the system starting to do things that they're not traditionally known for. And so we're trying to learn how to become a better health system. And so you have those performance issues. And then if you think about the value of a patient, the average patient's worth about $14,000 a year in healthcare per capita healthcare revenue. Average life expectancy of about 76 years. So each patient's worth about $1 million if they're receiving care effectively through the healthcare delivery system. So this tells us that A, we have a problem, and B, there is revenue out there related to delivering care the appropriate way and in the most effective way. And we know that today, the quality of care, just by the fact that 35% of all patient appointments go unused in this country, that there's opportunities, and that patients perceive that the biggest issues that they have really are around how they effectively utilize the delivery system. Every 5 years, the average primary care panel turns over by about 50%, and 78% of those patients say that they leave the system due to poor navigation. In a recent survey, about 60% of all patients said they really actually are seeking to be engaged in the system at a deeper level. And then we know a very similar percentage, about 57% of all STARS measures, are related to patient satisfaction and access. So when we think about referral management, it's really right in that opportunity spot that we have. So when you think about those challenges that we just talked about, it's really important that we think about how do we focus on keeping referrals in the network, what are our communication challenges, and then insights and reporting. And so what we're gonna spend time with today is going through our panelists in these three major buckets and really trying to understand where we have opportunities to improve the referral management systems that we have, and the way that those improvements can help us improve the overall performance of our healthcare delivery functions. So with that, I'm going to start, Mike, with you as the first recipient, and I think this is a fascinating stat. So a recent survey of hospital CEOs. And one of the results of those was 94% of all CEOs are concerned about keepage. And that's really the same concept as leakage, which means that in almost every health system in this country, and the reason that that's important, if you think about ACOs, and right now we have roughly, 450 ACOs, and about half, a little less than half, are what they call high revenue, or ACOs associated with a health system. That gives you some insight into the fact that we have a large section of our group that's really concerned about a huge opportunity. So what I'd like, Mike, is if you could, and I'll start us off with, when how do you track cost and quality information to create kind of the narrow networks, or that network of providers that you use and work with your referral coordinators to make sure they're supporting your primary care physicians?
In a word, it would be difficultly, but let me start with a little bit of a process, right? The first is the recognition of information that we've been able to acquire over the last decade or so. Before the ACO business was around, hospitals and delivery systems, they knew, and if they were taking any kind of risk, they might know that they know what happened in their facility. Or if they're not taking risks, let me be more precise. They're not taking risks, they're all fee for service. A decade ago or thereabouts, I had an orthopedic procedure. I know Dr. Smith did the surgery, and that's what I knew. I didn't know necessarily who the primary care physician for that was a decade ago. I didn't know if that patient was seen by some other external or unfriendly provider group. I mean, I knew nothing of that environment. It was a complete black hole. Along come the ACOs, and suddenly we're now seeing all claims for that population that's been assigned to us, and that's a step up. Except for those are the patients that are routinely coming to us as a general rule, right? Where 51% of their care, more or less, would be, so they're already aligned, and that represents the patients I have my arms around. That doesn't get to the keepage and the leakage, right? We looked at leakage, right? What are the patients that we could get our arms around, right? We're still kind of blind to that. And then CMS came up in the ACOs and gave you all the claims data for assignable. And at that point, it became, eye-opening for some. Certainly, I traveled the country, And when I explained this to some of the hospitals that we work with, they had no idea. So 94% of the CEOs are somewhat aware that they have an opportunity or a challenge or an item to be managed. I don't know where the other 6% are. You know, are they looking out the window? Right? Are they got their day timer book because they're, you know, oh, so current with tech and counting the months till they retire or something? So if they're not concerned about that incremental volume, someone else is, right? And hospitals, being a recovering hospital administrator, I know the economics of a hospital administration. We are really gigantic fixed cost machines, right? Our volume can go up and down, heat, water, light, depreciation, interest, you know, et cetera. Those remain constant. Staffing has a little bit of flex, but not in the real short term, only over, you know, an intermediate. Incremental volume is probably where all their margin is coming from. They'd only have to lose not, you know, 1.2% of their volume. If they lost a 0.5% of their volume on revenue volume, they wouldn't have a bottom line, because that's how much the incremental contribution over variable to fixed and all that kind of stuff is. So we understand that concept, and so we try to understand where all the constituencies are, and then educating the why. Without the why of this, now you're just in this lecturing of, you know, what, and that's an uphill climb. So I know that kind of a long-winded answer, but that explains the why we are so concerned for our constituencies to understand referrals. What does it mean? What does incremental volume mean? Positive and negative, right? So it's a big education process is where we start with.
Yeah, you know, I think it's interesting, Mike, that, you know, what a great answer, and gives everybody here fabulous insights into the current kind of state of where we're at today. You know, I read recently that a little over half of all referrals, whether the physician is employed or not, goes to somebody they just have a prior relationship with. So even in situations where there are a narrow network or a PAR network or a group of preferred physicians, even then it's hard to overcome the relationships. And so I think that reinforces your point, and kind of makes that uphill battle even that much more difficult.
I'll add a little bit of answer and then I'll kick it to Debbie. Explaining how much money is on the table in any number of different settings, when I'm sitting down with physicians, when the team sits down with physicians, and explaining the underlying economics of it, the most often occurring phrase when meeting with a physician and reviewing the claims activity and things of this nature, when the first time they've really been exposed to the total cost of care or the elements of cost of care, they're awestruck how much everything costs. And then you add on, well, you know, if you're going to support the system, you know, here's the revenue that left us, right? Half the cost did not.
Right.
In, you know, so
Yeah.
just constant, right?
Yeah. So that's
once
a great
you get into that, educated that, then that behavior mod becomes a little bit easier.
Mm-hmm.
And, you know.
Yeah, great segue into the question I want to ask Debbie. Which, Debbie, how do you incentivize or manage your providers so that they are sending referrals to your in-network providers?
Yeah, so being a primary care only ACO, we have core requirements that the primary care docs have to meet every year. And one of those core requirements is that they have to use our referral system, which is Proficient Health. If they don't use the referral management system, then they are in jeopardy of losing their shared savings. So it's a pretty big carrot that we put out there, and hopefully it's not a stick. And then on the other side, what we do with our specialists, because we have a high value specialty network that is built around our primary care ACO, that the providers, the PCPs refer to. And on the other side of that coin, the specialists have to pick up the referral within a certain amount of time, depending on what kind of referral it is, and see the patient, close the loop, etc., in order to maintain their status as a high value specialist. So we do both sides. We incentivize the PCPs that they have to use the referral system, and then on the specialist side, we incentivize them to make sure that they pick up the referral and close the loop on the referral, see the patient, send the notes back in order to maintain their status in the high value specialist network.
That's fabulous. Thanks for sharing that with us. And I'm always a firm believer that that contribution should align to compensation. And in so many parts of our system, those two things get misaligned. So the fact that you've lined up the compensation component and the contribution to the way the system works, I think is a great system to have set up. I think at this point, we have a quick survey question we want to ask, quick poll question.
Yeah, all right. So I am going to pull this up here. The question is, are you still receiving referrals via fax? So select one, yes, no, or not applicable, and I'll share the results here in a moment. This is, of course, anonymous. We'll give it about 10 seconds for folks to put in their answers. And no shade on the fax. It's a very secure line of communication.
Especially the electronic faxes.
Very old, albeit, but secure. Hey, wheels are pretty old too, but they work pretty darn well. All right, I think we've got most of the answers in, so I'm going to go ahead and close it down in 5, 4, 3, 2, and 1, and we'll share the results here. All right, are you guys able to see that?
Yep.
Yeah.
So about 80%.
Yeah, it looks to be.
Mm.
Yeah. 44% were willing to answer. 40% were embarrassed to answer.
Or no, but
Exactly.
yeah. I'm sorry. That's probably of those that are either yes or no. A little over 2/3, right? So that's significant.
Mm-hmm.
Yeah.
All right.
Cool. All right.
All right. So that's kind of to set the stage, as you guys might have imagined, we have this planned. This next part of our conversation, which is really around communication challenges, and I think this next stat that we like to highlight is fascinating. So, up to 50% of physicians do not ever know if the patient was actually seen by the specialist they referred them to. A very similar stat that the people often quote too is about 50% of all potential referrals are leaked outside of the system. So whether or not they actually see somebody, you also have that same impact of that they don't go where you want them to go, even if they go to see somebody else. And so both of those, to Mike's points earlier, really do have a significant financial impact. And I was reading a study from Duke University, and they actually they did a study of their own referrals, and you got to figure this is a pretty sophisticated system, and their results were about 36% of folks actually resulted in appointment from referrals prior to automation functionalities. So we really do see that there's a great opportunity, and that poor communications really does drive a lot of the less than desirable results. Debbie, if I may, I want to ask you, how does poor communication affect the referral process within your organization and even outside of your organization? And then what strategies have you seen or do you use to close that loop?
Yeah, so prior to us having a referral management system in place, it was very difficult, obviously, as everybody struggles with making sure that referrals are accurate to the right place and closed and things like that. We now have, with our referral management system, we now have population health specialists specifically for our specialists and for our primary care docs. And we have all kinds of trackers and information that we track on complaints about specialists, not getting the referral and not communicating back, and same way. So we also have work groups of primary care and specialists on how can we do it better, what can we do better, how can we communicate in a more effective manner. And we've seen a great uptick in our referrals, in our communications. The physicians are much happier because they feel like they are part of it, and they can talk to the primary care specialist or whatever. And so the communication, in my opinion, is key, because as all of us are in this business together to take care of patients, then this is the communication between the providers is what's going to help satisfy the patient experience.
That's a fabulous answer, and I think really powerful insights. Mike, do you have any additional thoughts for kind of how poor communication affects the referral process, and any solutions you guys are using?
Hard work. The changing workflows, right? Where I used to have, the preferred specialist, right? You do the big analysis. This is our low cost episode of care for, activity X. And we'd pull the primary care physicians together for dinners. And actually, I ran a risk IPA in Orlando a long time ago. We'll just say it that way. And we'd pull them together, and the specialists were always like, the primary care physicians don't want to hear from us. And it's like, oh yeah, they do. Right? And we'd get them to come to dinner, right? Buy everybody a really good dinner. The specialist always amazed at how much the primary care physicians wanted to know. Was always surprised how much the primary care physicians were engaged in, what do I need to prep the case so that you get what you need to treat them efficiently and effectively. And common phrase for me from that time period is, the specialist that gives you the discounts is not necessarily the least expensive. It's a specialist who calls you before the patient got to their car, right?
Right.
And rare as that might be, now we have electronic communications. If that EMR is set up to where I get an automatic update, I can now engage with that patient, and I have to be a primary care physician that actually sees that I made a referral. I ask you about the referral, and then I have the information from the referral. Now, as I mentioned a moment ago, we've done the big analysis, and we do it all the time. It doesn't change that often, but you got to do it. Which specialists are actually the most efficient and effective? And that's in reverse order. They have to be effective before they can be efficient. Another Mikeism. You cannot make an ineffective process efficient. You cannot do it. Right? So the once you get to that point, then how do you track Dr. Jones? Are you sending it to Dr. Smith, or are you sending it to Dr. Wesson? Right? And so that's like one-on-one communication. And until you get a tool for the referral coordinator, and it'd be a really interesting study. What percentage of primary care physicians have a referral coordination tool for the referral coordinator? Right? You're at checkout. Oh, doctor wants you to go to a cardiologist. Click. Right? Oh, here's the preferred. Click. Tuesday at 3 o'clock. Now the referral has been at least scheduled. They can still no show, but now it's massive improvement over, okay, we got this big report, Dr. Smith. We want you to send it to Dr. Jones. And then 3 months later, we're coming back saying you're not doing it. You got to get tools. I mean, we have technology, please.
Yeah.
Right.
Yeah, I think the other thing, just to continue that line of thought, is we all know that doctors love data. They hate data, they love data. They love it when it makes them look good, and they hate it when it doesn't. But here's the thing. When you have a good referral management system where you can show them data and show them, the time to close of a referral, or how quickly they see patients and things like that, it does make a big difference to both the primary care and the specialist, because they want to do better. And when you show them that, well, here's where your peers are, that also, of course, we all know that will incentivize them to do better also.
Absolutely. Recently the National Patient Safety Foundation, recently a couple years ago, published results of over 100 million specialist referrals that they analyzed. And so, Mike, I'm going to answer one of the things you asked about, but about 41% of them use an EHR referral capability. So of these 100 million referrals, 59% were handled either by fax, a little over half, or a little under half by giving the patient a piece of paper. And so not only do you have the importance of referral management functionality, but if you're going to do something in paper or put it into the patient's hands, you also equally need some type of patient engagement type functionality to engage and navigate patients, which is something that we don't normally talk about when we talk about referral management, which is, there's opportunities in that space as well. So Debbie, are you seeing any emerging technologies that are helping you support this, kind of outside of what we've been talking about, or in addition to what you're using, or including what you're using?
Well, I think the best tool, I haven't seen anything data-wise better than what we have, but I think, again, the best tool that you can use is a referral management tool where you can run your reports, you can show the physicians their data, the practices can run reports on their own referrals and closing loops and things like that. It's baby steps. It's baby steps when it comes to something like this. And so I think that, I would say this, as Mike said, you have to have a tool. You have to have something in your toolbox that will allow you to manage referrals, or else the leakage will continue.
Yeah, let's drill down into that a little bit. So, so let's talk about reporting and insights a little bit. I think that was one of our buckets. And when we started off, we talked about the fact that 94% of all CEOs were concerned about keepage. Now here's the other half of that stat, which I think is fascinating. 90% of them are not confident that they have visibility into patient leakage. So they know they have a problem. They're not. I think there's lots of opportunities for them to figure out the best opportunities to resolve these. And when you think about data that's required to better manage referrals, and then are you getting the data? In many cases, we're not, right? So in a Medicare ACO, there's opportunities, and you get more complete historical data. There's a little bit of a lag, but you have that. But in a commercial risk contract, or as part of a health system where you have your own employed primary care, it is really hard to get all the information that you need. So it's really, really important that you have those close relationships, and that you're creating that transparency and creating the incentives and the alignment for everybody to work together in that. If you think about what data you need to get, besides all of it, which I think was Mike's answer, it starts with, are they at the right type of primary care? Are we sending them to the right specialist? Are we, are we passing along the reason for the referral? Is it being reviewed? all of those key components, and then are we reviewing the consult when it comes back into the system? And so there's not only the access to data, but are we using it? And just personally, I don't think I've ever been to a specialist who actually knew why I showed up, but that's neither here nor there. So Mike, I'm gonna start with you if that's okay. But can you give us some thoughts on how you feel, what data is required to better manage these referrals, and
Sure.
how do you get that data?
Well, I would tell you, if you're at risk, if you are at downside risk, and you're not getting 100% of claims from that contract, terminate it today. Right now, get off the webinar, send the term notice. Because they're writing checks out of your checkbook that you can't possibly reconcile. I would not let my neighbor write checks out of my checkbook, right? Please. So 100% of claims, and when they tell you, oh, our pricing is proprietary, you still send a term notice. It's your money, right? All these targets are like, 85 plus or minus a couple points. It's your money they're spending. I couldn't imagine a TPA for an employer group go, well, just send us some money and, we'll pay the claims and we'll kind of sort of tell you some big numbers, right? Not in a life, right? Not in a moment. So data. And then there's a whole series of analytic steps you go through that you can infer referrals by, they saw primary care, 60 days later, they saw a specialist. That's an inferential referral if you don't have the direct referral within your system. So there's all kinds of groupings like that you can do. And really what you're looking for are the outliers, right? The guys who are not playing ball the way that you expect them to play ball, right? And peer pressure goes a long way. So that get the data, and then it's a matter of making sure you can track that patient longitudinally and know who your efficient people are. And then the tools, as we mentioned earlier, you got to make it easy. 3 ways to get anybody to do something: ask them, pay them, do it for them, right?
Absolutely. I'm going to tease out just one point you made because I think it's so important, and it's a unique opportunity, particularly for those in at-risk situations, right? When those ACOs or provider organizations are able to get all of the claims data, they are able to amass now a deep, rich healthcare focused data set that not even the payer has, because they have their own information plus that. And so they really do have everything you need to engage both the patient and the provider and manage the performance of the care and the way it's being delivered through a very transparent, deep, rich healthcare data set. So I think that is a fabulous answer, and I couldn't agree with it more. Debbie, I'm going to transition us a little bit into reporting, if that's okay. How do you use real-time reporting to make informed decisions? You'd brought up reporting before, and I'm just kind of curious on your capabilities and how you use that.
Yeah, so we review. We don't quite do as deep as what you alluded to about reviewing the referrals themselves and things like that. But we do review our reports out of our referral management system on a monthly basis to ensure that everything is being done by the core requirements. PCPs are using it. And by the way, we have, we are a hospital system and independent providers. So we have about 32 different versions of EMRs of all types. And so it would be very nice if everybody was on the same EMR. It just drew referrals in that EMR, but it's a challenge. And that's one reason why we went to a tool, because in order to manage these referrals and find out where patients were going and find out where doctors were sending their patients, we had to have that tool in place. The other thing is, and going back to the other question, the other thing is PCPs now, they have to be empowered to take better care of their patients. And for a long time, they would just go ahead and refer patients out to specialists and things like that. Now they're realizing that they can do more in their office and refer what is appropriate to be referred out to the specialist or to the hospital. And that also helps with the communication between everybody. But I think I got off on a tangent here,
So, Mike, do you have any, I think we're kind of finishing up our formalized questions. Any thoughts around real time or the use of reporting?
Well, a lot of our reports don't have total lines. A lot of our reports have average lines, and they're structured such that if your name is above the average line, you're helping the cause, right? You're above average. If your name is below the average line, well, you're hurting the cause. And we like that kind of reporting, and we don't do real-time reporting. We do it periodic, and it takes a little bit of a lift to get those reports put together. And we go out and show this to our groups of doctors. Well, doctor below the line, two things start to happen. If I'm just below the line, then I'm very optimistic that I can get above the line, right? And the line, when I do that, the line goes up a little, right? Continuous process improvement. The guy who's distantly below the line, they have a choice to make. Can they really change what it is they do, how it is they do it, or do they have to leave the note? And we've had a couple docs turn and go, I got to send my orthopedics to my wife, my spouse, right?
Yeah.
Right? You have to deal with some of those things, but we've had a couple docs raise their hand and say, I'm not going to change my behavior, I opt out. And okay, fine, right? You're going to be better off and more successful somewhere else, and we'll find our own success this way. But it's all about giving the doctors, they're technically trained as a scientist, right? They want data that proves something. And then there's the what, then what, so what kind of elements.
Mm-hmm.
Where we fail, where I see we do it all the time still. And I bet you everybody here has seen this. You're trying to educate the doc, you're doing all this data, and the doc goes, just tell me what to do. Right?
Yeah.
That's the fatigued concurrence.
Yeah.
Right. You might get some adoption, but you're going to have to go back because you really got to get that education there. Make it dirt simple, right?
Yep.
For them to act on. So that's reporting gets their eyes open, their heads open. Oh my gosh, I'm being measured. Can I comply with this and get above the line reasonably easily? If not, and there was another concept that we used to have in implementing anything. We called it owning Monday morning, and actually it was really owning Thursday morning. Some provider in your network, whatever the idea may be, referrals or whatever it might be, is the person who has the most opportunity. You get your Tiger team, your implementation team, whatever that is, you show up on Thursday morning, and you're going to replace whatever their existing workflow is with this workflow. And I would challenge that 80%, I'm hedging, I was going to say 90, 80% of the people who are the physicians that have the most opportunity probably are on the board. So here's this decision made by the board that this is a great thing to do, and the person with the most opportunity is in the room when they make that decision.
That's correct.
Right? Okay,
correct.
doctor, see you tomorrow morning.
Yep.
Like, what? You're really going to do this?
Yeah.
That's great, and a great insight. Probably the one thing I want to kind of leave, in addition to the discussions we've had, by the way, Debbie and Mike, fabulous insights into both reporting and insight of insights. The one thing that I would share that I think we also need to think through as we're establishing our reporting and insights for our providers is making sure that we actually literally really know who our physicians panels are, right? And if we're going to manage physicians and their performance on the primary care side, managing really knowing who their panels are. I would say that most times when we go talk to a health system, they don't know how many patients they have. They don't know what their addressable market is. They don't. We did a recent study on 180,000 brand new attributed patients to a large primary care group, and only about 20% of them were even attributed correctly. Right, so the payer attributed them based on their methodology and not based on the docs that had availability and spoke the right language and all of those things. So, address. So, when we talk about kind of, reporting and insights, one of the things we also want to make sure that as we get our data established and we're working with our providers, that we're setting them up with really that deep understanding of the panels that they have and how that aligns up. Because then that drives everything else through the system, and it drives our ability to report on it. It drives our ability to get deep, rich insights from all the data that we've been talking about. So as we utilize enhanced functionality, particularly in referral management, set up through insights, really important and critical in making sure we have the right tools.
And John, I'll just say this. Do not rely on payer data, because payer data should be a guideline, used as a guide, not as the source of truth. So again, data, have tools and use that as a guideline.
Well, we're going to take that as Mike.
I want to add one. I went back, as colorful as I was a moment ago about getting all the data and 85% of premium contracts and all that kind of stuff. Attribution, knowing the payer's attribution logic. I don't want to make this a managed care contracting webinar. You have to know absolutely. And when they say, "Oh, you got a new patient," you say, "Great, give me 2 years of claims history."
Mm-hmm.
Right? Because you might see that they didn't have a claim for 2 years, and now that they have a claim, dread disease 57, organ transplant, they're yours, right? Payers, it's only money, honey. So attribution, and then that referrals, you can't rely on just a single payer's data. If you don't have a good vendor for the Medicare 100% file, get one.
There you go. So I think those all fabulous points, and really appreciate you guys taking the time. I have to believe that there are a question or two out there for us. So Garrett, I'm going to let you step in and kind of guide us on the Q&A piece.
Indeed there are. First of all, fantastic presentation, guys. This was a lot of fun. I really enjoyed listening to y'all and some great insights shared. Yes, we do have some audience questions. If you have a question and would like to submit it, go ahead and do that now using your control module in the question spot. And we're going to get to as many as we can. In no particular order, the first one is, I believe, for John. How do you believe patient engagement plays a role in your referral management strategy?
So, I think engaging the patients in their care, A, is something that they want, and B, will help improve the performance and the results of referral management, and actually just closing care gaps in general, right? And so, as we think about getting those patients engaged and navigated to where they need to be to optimize their health and their health outcomes, I think is a real kind of critical emerging hotspot within our healthcare delivery, and I think using a strong referral or patient navigation functionality is really critical to the overall success of any network-based organization.
Yeah, great.
I was going to comment
Yeah,
on that
yeah,
earlier. Patient engagement actually starts before the referral.
Yeah.
Right.
Great.
Yes, it
Right.
does.
It looks like you're going to need a new knee in 6 months or a year or something like that.
Mm.
Start informing the patients what system, what orthopod, whatever, whoever that referral directive is going to be, who you're getting your best results from. Tell the
Right.
patient you're engaged in their health. I'm concerned
Yeah.
about the specialist you're going to see. Right. Starts earlier than
Absolutely. And a fundamental underlying component that makes it successful is making sure that that engagement's personalized to that patient.
Yep.
'Cause that's what we all want.
Yep.
Yeah, great points. All right, next question here is, I believe this one is directed to Devin. Are there any best practices you would recommend to help the PCPs know which specialists provide best cost and quality?
So we have reports on our specialists through claims data from the payers. And we are in the process now of really doing deep dives into that claims data to look at utilization and costs and where they're sending to. We, in our area, in the Raleigh market, we're really blessed to have really good healthcare systems with Duke, UNC, and Wake Med. But not everybody has to go to Duke and UNC. And so, you have to look at where they're going and then sit down with providers and say, did you really need to send, sit down with the specialist, did you really need to send, that patient to that specialist at that facility? So it's a matter of looking at the data.
Great. Next question here, and this is interesting, and I'll ask this one to Mike, and then you guys can follow up if you'd like. Following up on the patient engagement, quote unquote, how do you handle shared decision making when the patient prefers an out-of-network provider or hospital?
That went a little bit different than I first expected. We actually try to train our doctors to use, I want to make sure I'm sharing this decision with you for the CAP survey training, right? Shared decision making. You use that terminology because then the beneficiary will remember, oh yeah, they said that. And then there's a little bit of a push, but if the patient says, listen, I really want to go to, the Red Badge of Courage, Uber, Healthcare Central,
Right.
you really can't stop them, right? You can explain that, you may be kind of more of a number there if that's really the differential. Is there really a qualitative difference between the organizations? Real qualitative outcomes in the modern day, very, very small and is very unpredictable on a case-by-case basis. So, you can't stop them, but I'm not convinced that, and except for in rare circumstances, is there really any qualitative difference? And here's the thing, if anyone thought the doctor that they're sitting in front of was going to get it wrong, they wouldn't be in front of that doctor. So now it really is that customer service perspective, right? You can kind of push a little, but not hard, right? You can nudge, but right.
Yeah.
It also depends on benefit plan design too. So that's also an underlying factor.
I had
Great point.
fine point on that one. When I was running my risk group here in Orlando and IPA, we had contracts with the big Medicare Advantage health plans. Local health system bought one of the big cardiology groups, and they literally closed on a Tuesday. And on Wednesday afternoon, I got a screaming email from one of our docs about his patient was screaming at him about cost shares because they went from being billed physician office to hospital outpatient. The benefit plan went from $50 to a bunch more, right?
Wow.
And we didn't know this, at the IPA. We researched it, figured out. I sent out what this means to our medical directors. We had North, Middle, and South, and they sent it out to all their physicians saying, what this means is your patients are going to go from a $50 copay and a cost of X to $250 copay,
Yeah.
and a cost of X times 5. That cardiology group ceased getting any referrals on Thursday from our group.
Wow.
Went from large number to 0. Why? Because the primary care physicians did not see a qualitative difference between that cardiology group and that cardiology group.
Mhm.
If there's a qualitative difference, please send them to the best place in town. There's no such thing as cheap bad medicine. I can't make that determination. Those are doctors, but I know what they did.
Yeah, that's a great
Reinforces what
point.
Debbie said about benefit plan.
Gosh, that's a great point. Unfortunately, we've got to wrap up now. So we are out of time. But if you have a question that didn't get answered, we do have a couple that came in. Don't worry, someone will get to you through email afterwards, and we'll make sure to answer that for you. So real quick, I want to thank our speakers, John, Debbie, Mike. You guys were great. This was a very enjoyable conversation. Obviously, a lot more to be had here. Who knows? Maybe we'll rehash a part 2 at some point with the same crew if you guys are open to it. But as we close out, I wanted to encourage you all to go to BBC Exhibit Hall and check out the Proficient Health virtual booth. Proficient Health is who sponsored the webinar today. They are a leader in referral management and provider communication solutions. They help complex health and provider networks align every aspect of referral management to provide better patient care and strengthen financial and operational performance. And if you'd like to learn more about them, in the slides, we're going to have this little virtual booth, and you can click on that link. It'll take you there. There's a lot of cool resources, and you can check that out and contact the team if you would like. And then finally, if you would like to reach out to the team, to either any of our speakers or to the Proficient Health team, feel free to reach out to Rhonda, whose email is there at the bottom, and she will answer your questions and connect you accordingly. Or feel free to reach out to me too. I'm happy to facilitate an introduction or to make a connection there. But wanted to thank you all again so much for joining us today. I know there's a lot vying for your attention this time of year, and appreciate you spending the afternoon with us. So we'll see you on the next one. Thanks, folks. Bye-bye now.
Thank you.
Thank you.